We're going to talk about surface anatomy for the cervical spine. So first, we need to get oriented. And to do that, we need to find the Frankfurter neutral position. So we'll ask our subject to turn to the side. And the Frankfurter neutral position is defined as the most dorsal part of the occiput in line with the most dorsal aspect of the thoracic spine. Then we also look so that the lower border of the orbit is in line with the external auditory meatus. Now we're going to go through finding the ventral structures that will correspond to deeper spinous process levels in the cervical spine. And we're going to start the first time. I'm going to show you from the front, turn to the side, then we're going to continue with finding just from the front, and then we'll correspond at the end looking at the side one time to avoid too many position changes. So how do you come back? So first we're going to find the hyoid bone, which corresponds to the level of the C3 spinous process. Get her sitting up tall. If you go up underneath the mandible, you feel for a horseshoe-shaped bone, which is the hyoid. If you're not sure if you're on it, you can ask your subject to swallow. And you'll feel that horseshoe-shaped bone drop down in between your fingers. Once you find it, we can draw this in. There we go. Okay, now we'll ask our subject to turn to the side. Sit up tall. If I place my fingers right over the hyoid bone, go straight dorsal, that should correspond to the level of the C3 spinous process. And we will continue this process from here. Let's come back. The level of C4 is at the level of the V-notch of our thyroid cartilage. So for that, we will find our hyoid again. We'll come back to the midline. And you drop down about a couple millimeters on Whitney. And you can see that the V-notch, if we go medial to lateral, you'll ride up on a ridge. And you'll feel yourself in a little V. So we'll draw that. Be sure to use a light touch when you're finding these structures. We can go ahead and outline the remainder of the thyroid cartilage.
And down. Head back.
Okay, we've drawn our hyoid bone, and we want to be sure that we go straight dorsal from that point, and you can see my fingers should correspond with the level of the spinous process of C3. Then we've continued down. We found our V-notch of the thyroid cartilage. We've outlined most of our thyroid cartilage, which corresponds to the level of C4, and we'll see that in a moment. If you find the most cranial lateral aspect of the thyroid cartilage, continue on down, you'll fall into a concavity, which are your thyroid end plates. This corresponds to the level of C5. Come back to the ventral aspect of the thyroid cartilage, continue caudally, You'll fall into a little divot, and then you'll roll out onto a tire, which is your first cricoid cartilage. We'll draw that. This corresponds to the level of C6. So we have 6, 5, 4, and 3. So let's turn to the side. If we look now at our V notch, should correspond to the level of C4. Our thyroid end plates, C5. First cricoid cartilage, C6. Now we're going to find the transverse processes and articular pillars of C1 on down through C6. First, we need to find the mastoid process, here located at my index finger. You can push up and my finger does not go anywhere. I'm on the mastoid process. The C1 transverse process is going to lie just caudal and ventral between the mastoid process and the angle of the mandible. And it should feel like a little pencil eraser tip, and you can verify your location by side bending your subject's head towards that side, and you'll feel the C1 transverse process poke out into your finger. At that point, I can now slide my finger caudally. I'll fall into a divot, which will correspond to the level of C2. And then I go a little bit further and I get bumped back out onto the C3 transverse process. To go from here, I can go two different ways. I can pull my finger caudal, dorsal, and a little bit medial, and I'll feel myself ride up onto a bump. And that bump is going to be the articular pillar here, located at my distal phalanx. I can verify my location by side bending my patient's head away, roll my finger up on top of the pillar, and side bender towards the side that I'm feeling, and I'll feel that pillar close on my finger. Another way to check is simply to block. I'm on C3. I can now side bender head over, and that's it. There is no more motion after that point to check the pillar. You can also do this another way. We've already drawn our ventral landmarks. I can go back, finding C3, spinous process. I can now course ventral and lateral, and I'll fall into a nice concavity where my lamina are located. If I continue out laterally, I'll get bumped up and dorsal onto that articular pillar. So here it is again. Two different ways to find those articular pillars. And we can continue to do this up and down. So we found the transverse processes. C1, course caudally, fall into the divot of 2, get bumped back out onto 3, and then I can continue to go down the transverse processes, fall into a divot, get bumped out, 4, divot, get bumped out on 5, divot, get bumped out on 6, and so on. I can also come down the articular pillars, finding my C1 transverse process, falling into the divot, coming out on the C3 transverse process. I now pull my finger caudal and medial until I ride up onto the pillar, verify my location, Then I'm on the pillar. Now I can course down the pillars. Fall into the divot, onto 4, into the divot, onto 5, into the divot, onto 6. Going down the articular pillars or the transverse processes, however you would like to do that.
For surface anatomy at the back of the head and the upper cervical region, one can begin at the greater occipital protuberance. That's relatively easy to find at the back of the head. When you don't have a lot of hair, sometimes it's even visible. It is a midline bony protuberance that is approximately 2 centimeters up from the region where the head meets the neck. Here you can see this relatively easily. If you have somebody with a lot of hair in this region, it's easy enough to just take your fingers and gently stroke up the back of the head until you come to that prominence. Laterally, on either side from that prominence, is the superior nuchal line. One can go from the superior nuchal line, slide inferior to that slightly, and one can palpate the inferior nuchal line. These two lines are the insertion sites for several occipital muscles. When I have the greater occipital protuberance and the mastoid process, which is located here behind the ear, it's the large bony mass just posterior of the ear, and I place my finger midway between these two bony prominences. Generally, in this region, a pulse can be felt. And this region of pulse is the occipital artery. Generally, both laterally and medial to this pulsing structure, when one gently palpates with a fingertip in this area, you can roll over a spaghetti-like structure, and those are branches of the greater occipital nerve. Moving down from the back of the head, the greater occipital protuberance, the superior and inferior nuchal lines, the first structure that the fingers reach, just caudal to the occipital bone, is the posterior arch of C1. It can best be felt by palpating just lateral of the paravertebral muscles and posterior to the sternocleidomastoid. There one can have a fairly good grasp of the posterior arch of C1. Going back to the midline, when the finger slides further in a caudal position, caudal direction, the first rather large bony prominence that is felt is the spinous process of C2. And the spinous process of C2 can be palpated in a caudal cranial direction, and it can also be appreciated by palpating through the width of the paraspinal musculature, coming from the sides and squeezing gently until one reaches bony contact on each side. The largeness of the spinous process can be appreciated, and it's easy to feel each side from through the paraspinal musculature, because this bony process is bifid and again quite large. To find the transverse process of C1, locate first the mastoid and then the posterior angle of the mandible. And I think we'll turn our subject so that you can see that a little bit better. There we go. So, finding mastoid, locating the posterior angle of the mandible. I have those two bony structures. Between the two bony structures, just in front of and slightly below the mastoid, when I palpate, I can feel a bony structure, best palpated when moving the finger in a cranial and caudal direction. Sometimes it can be made more noticeable by performing a passive side bend motion in which the transverse process translates laterally to the side that's being side bent, and the transverse process is confirmed.
The lower cervical local examination is utilized to provide provocation testing for either our facet joints or zygapophyseal joints or the uncovertebral joints through a series of coupled and combined motion patterns. First, I'm going to lightly stabilize the patient's shoulders with my elbows, grasp with 2 fingers the forehead, and lightly place my hand over the occiput. I can ask the patient to turn their head to the right as far as they can. Then ask her to tilt her head back towards me, side bending to the right. Then I can ask her to extend and then to flex, attempting to provoke pain from the zygapophyseal joints through a coupled motion pattern. We can do the same testing to the left. Again, placing my hands over the forehead and the occiput, elbows on the shoulders lightly, turn to the left. Very good. Side bend to the left. Holding her at the end range and ask her to look up or extend. And then to flex. Very good. And then come back. That was coupled motion testing. Now we can move on to combined motion testing for our zygapophyseal joints. This is going to be accomplished through a combined motion testing pattern, whereby my coupling pattern is ipsilateral in the lower cervical spine, so I'm going to induce a contralateral side bending. So if I want to test the right side zygapophyseal joints, I will ask the patient to turn to the left, and I will induce now a right side bending, feeling the end feel, looking for provocation of symptoms. Come back up. To test the left side, ask her to turn to the right. Now I induce a left side bending. Good. Now we move on to the uncovertebral joints. So to do this, we're going to emphasize our primary motion of side bending versus rotation, which we use for the zygapophyseal joints. To do this, I want to stabilize the upper arm on the opposite side of my side bending to not allow the shoulder girdle to elevate. In this position, I will stabilize, ask the patient to side bend to the right, hold them in that position. Now they can turn their head to the right, looking for provocation in a coupled motion pattern. Then we can switch sides and test the other side in a coupled motion pattern. Stabilize, take them over to their end range side bending, and then turn to the left. Coupled motion. Then we can induce the combined motion testing. Stabilize, side bend to the right. You can gently reach over the top with 2 fingers on the jaw and give a little bit of a cue for a contralateral rotation for a combined motion testing of the uncovertebral joint. And again, stabilize, take them over into left side bending, 2 fingers cue to turn to the right. Combined testing for the uncovertebral joint. At this point, we have some information letting us know what structure is primarily involved. Is it the zygapophyseal joint, or is it the uncovertebral joint, or both? Or even possibly an internal disc disruption. Now we need to know what level is affected, or levels are affected, for us to know what to do for treatment, which will be coming up in a few moments. To do this, we need to do our C2 to C7 side bending end field testing. So if we can do this, we'll ask the subject to stand up for a moment. Please have a seat. This goes back to the surface anatomy. To do this, we need to find the mastoid process, go just caudal and ventral, find the C1 transverse process, fall into the indentation of C2, you'll get bumped back out onto C3, transverse process. At this point, I can pull my finger dorsal and medial, and I will fall onto the articular pillar as I get bumped back up on it. Once I'm here, I can check myself with the lamina coursing with the hyoid bone to ensure that I'm on the level of C3. Now I want to take my fingers and align them in a line like a karate chop to reinforce my index finger. I want to take up a little bit of soft tissue slack, pushing up into the articular pillar of C3. And if you'll notice, my fingers are coursing towards the orbit. This is very important to respect that joint anatomy orientation so that you don't end up with false positive testing. To do the test, I'm going to take my left hand and induce a side bending over the top of my index finger. Take her over, and right here, nice, very firm end feel. Take her back. I course down to the next level. Take up the soft tissue slack. My fingers are still pointing towards the orbit. Now we're testing C3-4, and you'll notice that she goes a little bit further. Feel the end feel. Bring her back. Move down to C5. Take up the soft tissue slack. Side bend her over. She goes a little bit further. Feel the end feel. Then C6. Take her on over. And then the last one, C6, 7. Keeping the fingers pointing towards the orbit. And we'll compare with the other side. So we'll ask Whitney to stand up, turn the chair so that you can see. And with this testing, we want to be sure that we compare motion from cranial to caudal and not from right to left. So I found C3, just as I did before. Fingers in the karate chop pointing towards the orbit, and side bend her over my finger. That's it. Nice firm end feel. When somebody is limited, it will be a very hard end feel and likely less motion. That was 3-4. We moved down. 4 on 5. Move down one more. 5 on 6. Then the last one, C6 on C7. Noticing that there's a nice subtle increase in motion as we go down each level. Let me turn her so that she's facing you so that you can see the subtle increase in motion with every test. We'll test her left side again. She sits up tall for me. Use my landmarks, C1, transverse process, fall into the indentation, come back out on 3, course back on the pillar, Take up the soft tissue and relax for me. Here's 2-3. That's how much motion she has with 2-3. Move down. 3-4. 4-5, a little further. 5-6, a little further. 6-on-7, a little further. Every time should be a nice stepwise, incremental increase in motion. When you do the technique, it doesn't take hardly any pressure at all on the occiput. It's very light. I'm just gently resting my hands on the occiput. And with this test, we're inducing a side bending. However, don't fight the coupled rotation with the test. Allow it to occur. Move down to C3-4. Perform the test. C4-5. Perform the test. C5-6. And lastly, C6 on C7. Very light.
There are two parts to the alar ligament test for upper cervical stability. The first part, I'm going to test movement of C2 in relation to C3 and the occiput by simply placing my fingers on either side of the spinous process. My patient is in a sitting position. I locate the spinous process of C2, I grasp the top of the head, and I simply create a right and left side bend. When I do this, the spinous process of C2 will move opposite to my side bending position, and I just feel the swinging back and forth. Then what I'm going to do is I'm going to stabilize the C2 spinous process by placing my thumb on the side of the spinous process that's closest to me. I'm going to hold the occiput and the patient's head, obviously, and create a slight upper cervical side bend. I'm standing on the side that I'm testing, which in this instance is going to be the right side. I stabilize the right side of the spinous process, and I create tension in the right alar ligament by performing a left side bend. With left side bend, my C2 swings also to the left, making a left rotation, and that is going to be stopped now by my finger against the spinous process. If I have an intact alar ligament on the left, if I have an intact alar ligament on the right, and I stabilize C2, then I will not be able to perform any of the upper cervical side bend. It will be stopped by the alar ligament. So for the first part of the test, I'm simply going to locate C2 spinous process, side bend, right and left, and in so doing, I ensure that I can feel the spinous process moving opposite to the side to which I'm side bending. So I ensure that there's movement of C2. Now what I'm going to do is check in this position, specifically the right alar ligament. I stand on the side that I'm testing. I stabilize the right side of the C2 spinous process with my caudal thumb. My cranial hand is placed at the occiput and lateral side of the patient's head. I can create a very slight axial separation through the cervical spine. By doing that, I take out some of the coupling that occurs as a result of gravity resting on the cervical spine. So I give a slight axial separation, head is in neutral, stabilize C2 from the right side, and I'm going to now create a left side bend, which tightens the right alar ligament. If the right alar ligament is intact, I will not be able to perform this upper cervical side bend or side nod. If it's not intact, I will get some left side nod and a softer end feel. End feel is tested by simply bringing the head to the end range position and exerting pressure with my thumb against the spinous process. So a normal test would be stabilization of C2 against the lateral side of the spinous process, attempt to side bend away, but the intact alar ligament does not let me. I give overpressure, which should be hard now, with a normal alar ligament against the C2 spinous process. I can test the transverse ligaments in sitting by performing a lateral shear and also by performing a ventral shear. The lateral shear is done whereby I stabilize C2 by putting my thumb and index finger against the lamina of that vertebra. I am then going to grasp occiput and C1, and I'm going to pull the occiput and C1 in a direction horizontally towards me. So it's a horizontal translation toward me. The ventral shear is performed simply by holding the lamina of C2 down in a caudal ventral directed position, and I'm going to grasp again occiput and the posterior arch of C1 with my ulnar side of my hand, creating a supination of my cranial forearm so that I get more specifically into that space, stabilizing C2, and now I'm going to pull occiput and C1 ventrally forward in a horizontal translation maneuver. So it looks like this. Patient is seated comfortably. Lateral translation test for the transverse ligament, stabilizing C2 against C3. The moving hand pulls the occiput and C1 towards the examiner in a horizontal translation position. So I'm pulling towards me in a horizontal position. I'm looking for symptom provocation of not feeling very good or feeling like the patient's going to black out. This is not a test for pain provocation or for range of translation. I hold for 30 to 60 seconds, pulling first towards one side, and then I repeat the test with a translation to the opposite side. The ventral translation is performed with the same hand placement. I push C2 against C3 with my stabilizing hand. My moving hand now comes a little bit more posterior or dorsal on the posterior arch of C1, grasping occiput and C1. I pull the head forward in a protracted position and at the same time exerting a ventral translation, a pure ventral translation to the head and C1 region. Hold it 30 to 60 seconds, looking for symptom provocation of nausea or feeling like our patient is going to black out. This is not a test for pain provocation, nor am I trying to feel the range of translation. holding 30 to 60 seconds, and then relax. Lateral translation of C1 in relation to the occiput is one test done in supine for the integrity of the transverse ligament. The examiner stabilizes C2 with the index finger, the radial side of the index finger, and stabilizes the mastoid with the thenar eminence, leaving space for movement of the transverse process of C1. The other hand is going to locate the transverse process of C1 and simply give a medial force translation, creating a lateral translation of C1 in relation to the occiput. This is done first on one side and then on the other. Radial side of index finger on the lamina of C2, thenar on the mastoid, leaving space for the transverse process to shift. The other hand simply pushes against the transverse process of C1, creating a translation laterally of C1 in relation to the occiput. It looks like this. If I'm going to translate C1 to the left in relation to the occiput, I locate transverse process, place my moving hand against the lateral aspect, my stabilizing hand locates C2, I lay the radial aspect of the index finger of the stabilizing hand against C2, thenar against mastoid occiput, hold the position and push the transverse process in a left translation direction, looking for symptom provocation of nausea or feeling that the patient's going to black out. This position is held for 30 to 60 seconds. The same is then done on the opposite side. Stabilizing hand now rests by resting the radial side of the index finger against the C2 lamina, thenar against the mastoid, leaving space for C1. The other hand localizes transverse process of C1, and a lateral pressure is exerted against the lateral aspect of the transverse process. Position is held 30 to 60 seconds. Ventral translation of C1 in relation to the occiput, testing again the transverse ligament at C1-2, is performed by stabilizing the occipital region against the back of against the table. C2 is located and the moving fingers are then placed between C2 and the occiput, which is going to be the posterior arch of C1. The examiner places either the index fingers or the middle fingers against the posterior arch, uses thenar eminences to stabilize the occiput, and the force is simply applied by means of an flexion of the index or middle fingers, and in so doing, the C1 vertebra is lifted in a ventral direction. Patient's head is positioned in a neutral position. C2 located, middle or index fingers are placed against the posterior arch of C1. I like to use my middle fingers reinforced by index finger. Some people use index finger reinforced by middle finger. Occiput is stabilized just ventral of the ear in the region of the zygomatic arch. I place pressure in a posterior or dorsal direction and gently lift C1 in a ventral direction. Lifting C1 in a ventral direction. Position is held 30 to 60 seconds. And this is a test purely for symptom provocation, not for pain, nor for excursion of translation. Vertebral artery testing is performed in instances where the clinician wants to provoke the patient's complaints of dizziness or nausea or vague complaints of symptoms in the head, neck, and upper arm region. When performed as a provocation test, each position is held at end range in a supported fashion for up to 2 minutes. There is a 1-minute rest in between each of the end range positions. Should symptoms be provoked, the clinician is encouraged to hold that position for about 15 seconds and determine whether the symptoms dissipate or continue to worsen. If the symptoms dissipate, the positioning may be due to a simple upper cervical dysfunction. Should the symptoms worsen, the position is returned then to the normal neutral position and testing is completed for that session. The positions that are used in vertebral basilar insufficiency or vertebral artery testing start from the least stressful to the vertebral arteries and move to the more stressful. One of the first positions is simple cervical end range extension. The patient is instructed to let the examiner know immediately if symptoms should arise. The eyes should remain open, and the examiner is going to focus on symptom provocation and any nystagmus that might arise in the eyes during this positioning. So I'm going to inform my patient, I'm going to drop your head backwards, and the first position is going to be maximal, pain-free extension of the cervical spine. The eyes are held open, and a nystagmus can be followed or assessed once holding the patient's head in this position by having the patient follow movement of a finger at about 3 feet from the eyes in an arc over the head slowly and back again. And this eye following movement pattern can be performed at the end of every one of these positions. Extension is one position. End range, rotation. In each direction. Are 2 more positions, each held for 2 minutes with a 1-minute rest in between. More aggressive testing brings the cervical spine into extension, end range, right rotation, right side bend. Performed to each side, end range extension ipsilateral rotation and side bend. Two positions in flexion, consisting of flexion, rotation, contralateral side bend, and flexion, rotation, and contralateral side bend to the other side. Once one of these tests has been found to be positive, the entire series is considered positive and testing stops with that test. Soft tissue mobilization comes in many forms, and one of the forms that we can use in the cervical spine is a bilateral paravertebral muscular transverse stretch. We'll do that from C2 to C7, and the patient sits relaxed in a chair. If they're a little bit too slouched forward, we can place a towel or a lumbar roll in the low back region to afford a better upright posture. And the therapist stands comfortably next to the patient. Either side is fine for the bilateral technique. And because I'm going to be holding the patient's head against my trunk, moving the head in relation to my lower hand, I prefer to place a towel between the patient's head and my sternum. That allows for an upright posture and is a very comfortable position to use. First thing I'm going to do is locate the C3 lamina and transverse processes. I'll mark that segment with my index finger. I'm going to position my cranial hand so that the ulnar side of my hand is resting against the lamina of C2. I gently supinate my forearm of my cranial hand, and that allows for a little bit better localization on the cranial vertebra. I maintain an abducted position in my left shoulder, and that allows room for the patient's face. If I adduct, I will tend to pull through the TMJ and the jaw, and that can be quite uncomfortable. So upper hand is positioned. Now for the caudal hand, I'm going to actually slightly pronate my forearm here. That's going to allow for better localization at the C3 lamina, the level of the C3 lamina. I align my arms so that they're parallel to each other, in line with each other. And the technique is done by first gently taking the paraspinal muscles, squeezing gently, pulling in a dorsal fashion. That takes out the pretension of the muscles. Then I'm going to gently, slowly flex C2 on C3, thereby creating a transverse stretch of the paraspinals relatively locally at that level. So one more time, squeeze, pull back, flex, squeeze, pull back, flex. Notice that I am not sliding my fingers across the skin, but rather getting a feel for when I'm at the end of the muscle pretension as I near end range flexion at that segment. I can stay at this level and do several repetitions. And I can move caudally by placing my index finger of my caudal hand at the next level, placing my ulnar side of my cranial hand on the lamina of C3, and again pulling the muscles back at the C4 level, flexing now at C3-4. And I can continue moving caudally. Pull, flex, and another level. Down, pull, flex. Notice that I don't need a large amount of flexion in the head because I'm staying relatively local. So I can move up or down in this very gentle transverse stretch of the paravertebral musculature from C2 to C7. I can be even more specific by doing a three-dimensional extension or flexion transverse stretch to the muscles. And in order to do that, what I'm going to do is stand opposite the side that I want to affect. So if I'm going to work with my patient's right side, I stand on the left. They're sitting comfortably again. Place the towel between sternum and patient's head. And in order to do a three-dimensional transverse mobilization in the form of a paravertebral muscle stretch, I'm going to need to know the coupling in the lower cervical spine, which C2 to C7, which is an ipsilateral coupling. So as I move towards flexion, what I'm going to do, place my caudal hand on the lamina of C3, again slightly pronating so that I can emphasize that segment. My cranial hand is going to be placed on the lamina of C2. Now I'm going to position my elbow so that it is in line with the facet of the zig epiphyseal joint at that level, which is the local, running from the local curvature towards the orbita. So again, ulnar side of my hand, elbow in the direction of the patient's orbita. I start from a neutral position, and I'm going to move the head into a flexed, left rotated, left side bent position, at the same time gently squeezing the paravertebral muscles at that C3 level, gently pulling back to get pretension, and then moving the head in a flexed, in this position, left side bent, left rotated position. Gently pulling in a direction toward the orbita. Again, I can perform several of these maneuvers at this level. And if I choose to, I can move down to the next level, C4. Again, position my caudal hand in that pronated position so that I can snug into the soft tissue. Take out pretension by gently squeezing, pulling back, and top hand or cranial hand one more time, moving the head into a flexed, left rotated, left side bent position. And continue to move down to affect the C2 to C7 segments. Watching my elbow, making sure that it is positioned toward the orbita, making sure that I stay with my fingers relatively close together, and making sure that I do not slide backward over the skin as I work with my caudal hand, staying primarily in the form of a muscle transverse stretch. That flexion, ipsilateral side bend rotation, transverse stretch to the paravertebral muscles. I can do the same type of maneuver, but with an extension emphasis. And in order to do that, again, patient is sitting comfortably, lumbar roll in the low back if need be. I prefer to use a towel to keep the head in an upright position, place it against my sternum, locate the lamina of C3, position my caudal hand with a slight pronation of my forearm. Cranial hand is going to be placed on the lamina of C2 at that level. I want to respect the orientation of the facets at the C2-3 zig epiphyseal joint. So my position is going to be in a line from the local curvature toward the orbita. This time I'm going to create pre-tension in the local paraspinal muscles by gently taking the muscles at that level and pushing them in a ventral direction. Emphasis is on my radial side of my index finger. So here I go, finding 3, pre-tensioning the muscles at that level by means of a gentle push forward with the radial side of my index finger. And now I'm going to move the head in an extension, ipsilateral, rotation, side bend. In this instance, right rotation, right side bend, in order to get a transverse stretch of the right paravertebral muscles at the C2-3 level. I can emphasize locally, or I can gently walk my fingers down from level to level, 2 to 3 repetitions at each side, pre-tensioning by pushing the radial side of my index finger against the paravertebral muscles, pushing them forward, and then moving the head very gently in an extension, right side bend, right rotation, or ipsilateral movement pattern. Soft tissue mobilization to the upper cervical spine can be performed in a transverse stretch to the suboccipital musculature. Sitting is one position in which we can do this, and the patient should sit comfortably in a chair, but with an upright posture. So we're going to place a lumbar roll, if needed, there we go, for comfortable, relaxed, but upright positioning. I'm going to place a towel between the patient's head and my sternum, and that's going to afford an upright position of the head and will avoid the tendency to pull the head into a side bend that can happen if you don't put some sort of towel there between therapist and patient's head. In the upper cervical spine, we have 2 sets of muscles to consider. We have the recti, which are more midline, and we have the obliques, which are more lateral, running from the transverse processes of, for instance, C1 to C2. So I'm going to do this technique both with a narrow grip that's emphasizing the recti muscles, and also with a more open V grip that's going to emphasize the obliques. The first stretch that can be done is a bilateral paravertebral stretch, and that is performed through a flexion in the upper cervical spine. And a flexion in the upper cervical spine is more of a nodding motion. So what I'm going to do is I'm going to locate the C2 spinous process. My caudal hand comes in from a relatively perpendicular position. I pronate my forearm. I'm going to start with a wide grip, so pronate forearm, wide grip at C2. My cranial hand comes in And with the ulnar aspect of my cranial hand, I place it at the back of the occiput. By supinating my forearm, I get a little bit more emphasis on the occipital region. From here, I can move my cranial hand either either it stays at the occiput, or I can move it down one level to the posterior arch region of C1. Depends on if I want a more global technique or a more local technique. So, placing the cranial hand, good, patient gets comfortable. The mobilization, soft tissue mobilization technique looks like this. I'm going to gently pull the oblique suboccipital muscles in a dorsal direction by squeezing my hand, pulling backward. That creates a pretension, and then I'm going to perform a very gentle upper cervical nodding motion, and I can move my caudal hand more cranial to the level of the C1 posterior arch, each time giving a gentle squeeze, pull back, and then make the nod motion. So my caudal hand can go from C2 cranial to C1 using a wide grip, and it can go from caudal to cranial using a very narrow grip, emphasizing more the recti. If I want to have a more general technique, I stay with my cranial hand at the occiput. If I want to have a very local technique, I'll snug in, keeping my caudal hand, for instance, on C2, my cranial hand on C1, and just make local motions at that level, using either a wide grip or a narrower grip to affect either the recti with a narrow grip or the obliques with my wider grip. Moving up to C0 or occiput C1, I can do the exact same technique. Wide grip for the obliques, narrow grip for the recti. The transverse stretch to the suboccipital muscles can be performed in a two-dimensional bilateral movement pattern, or it can be performed in a three-dimensional pattern with emphasis on one side. And in order to do that, I'm going to stand on the opposite side to the region that I want to affect. My patient is sitting comfortably in the chair. I use a towel between head and my sternum. Locate C2. Using a pronation of my forearm, I'm going to emphasize that level, lock in a little bit, and my cranial hand can be either at the occiput or more in the level of the C1 posterior arch, depending on if I want a more global emphasis or a more local emphasis. The three-dimensional motion in flexion of the upper cervical spine is contralateral, which means I'm going to be performing an upper cervical nodding motion, and if I stand on the left side, I'm going to combine that with a right rotation. So when I perform the flexion motion, I'm going to rotate opposite to the side that I'm standing on. To stay coupled in the upper cervical spine, I bring in a left side bend during that rotation, and I can do that by gently dropping in my knees, and that will bring automatically that coupled contralateral motion pattern. Now, to perform the technique, I'm going to place my moving hand on the occiput, for instance, I'm going to take my caudal hand, I'm going to create a pretension on those suboccipital muscles. A wider grip emphasizes the obliques, a narrower grip emphasizes the recti. And I start at the C2 level. I'm going to perform an upper cervical nod, but before I do that, I gently take the paravertebral muscles, create a pretension by pushing them forward or ventral with the radial side of my index finger. So here we go, radial side of index finger, pronated caudal forearm, pretensioning the paravertebral muscles by pushing them forward, pretension, and then I make a movement, flexion, right, rotation, left side bend. Upper cervical flexion, right rotation, left side bend. In a very gentle, rhythmic movement pattern. Emphasizing more the recti, I can move in a little bit closer towards spinous process of 2, posterior arch of 1. Each time making the coupled flexion, rotation with contralateral side bend. That's the flexion movement pattern. In order to make an extension movement pattern, everything stays the same in terms of patient positioning, therapist positioning. One more time, localizing the C2 spinous process. My cranial hand is now going to rest either on C1 or on the occiput. And I'm going to now move in an upper cervical extension, which is a kind of protraction movement. So rather than going backward in a lordosis, I'm going to very gently pull my patient's head forward. And that creates the upper cervical extension. Because I'm pulling forward, I'm going to create a rotation toward me during this technique. And to stay coupled in the upper cervical spine, I'm going to bring in a side bend that's opposite. And I do that by gently raising in my knees. So I create the motion by pulling the head forward, bringing the occiput towards me, side bending away by means of extending more in my knees. Meanwhile, my caudal hand creates pretension in the muscles by gently squeezing, pulling backwards. So squeeze, pull backwards. Upper hand supinated, and I keep my cranial arm abducted to avoid creating pressure through the TMJ and jaw of my patient. So key is that cranial elbow stays forward in relation to the patient's neck. Okay, here we go. Pretension with the caudal hand, pulling the head forward to create extension in the upper cervical spine, rotate toward me, side bend away. And this is done, pretension, extension, rotation left, side bend right, to respect upper cervical contralateral coupling and get a very gentle transverse stretch through my suboccipital muscles. I can do it generally, moving my caudal hand between C2 and C0, or the occiput, or I can be very specific by moving now my cranial hand on the level of C1 and performing a very local movement, pretension, move. That would be C1, 2, emphasis. Occiput C1, emphasis. I move my hand up, to the region of the posterior arch of C1, create pretension by pulling backward, and again move the head forward in a protracted position to get my upper cervical extension, rotate toward me, side bend away. And now I have a local emphasis on occiput C1 in an extension, left rotation, right side bend maneuver. Soft tissue mobilization can also be performed in a supine position, and in doing that you want your patient comfortably lying on the table, perhaps some pillows under the knees for a neutral spine posture. We have to be very careful too that we respect the kyphosis in the thoracic spine, and if necessary, placing a pillow under the head. In this instance, we have a subject who's resting comfortably against the table, and head remains in a neutral position with head flat on the table. We're going to perform a transverse soft tissue mobilization stretch to the paraspinal muscles. This is done in a unilateral movement pattern, and in order to do that, the therapist can stand at the head of the patient, perhaps a little bit off to the side. What we're going to do is we're going to start at the trapezius region and move our way up to about the level of C2. When performing the transverse stretch to the trapezius, it helps to gently stabilize the patient's shoulder on that side. The moving hand comes in behind the region of the trapezius, and pretension is created by gently squeezing the hand together in a kind of lumbrical grip. So I come in behind the trapezius, gently hold the shoulder on that side, and I'm going to create a transverse stretch to the trapezius by pulling in a ventral, slightly medial direction. So here I go. Create pretension, stretch, create pretension with a lumbrical squeeze, then pull in a ventral, slightly medial direction. And this can be performed from the lateral aspect of the muscle, moving more medially until reaching the level of the lower cervical segments. At that moment, the stabilizing hand comes to support the neck on the other side, and what we're going to do now is continue the transverse stretch, turning it from a transverse stretch of the trapezius region to a transverse stretch of the paravertebral musculature on the right side. Once I begin to put emphasis on the paraspinal musculature of the cervical spine, I'm going to direct my force toward my patient's orbita. So I gently support the other side of the head and neck with my other hand. I grasp the lower cervical paraspinal muscles using my index and middle finger of my right hand, come in close to the paraspinal muscles at the lower cervical region, create pretension with my lumbrical squeeze, and then make a very gentle motion of For a more local emphasis of the transverse stretch to the paravertebral musculature in the cervical spine, the stabilizing hand can move to the caudal vertebra of the segment that you want to emphasize, and the moving hand is placed at the level of the cranial vertebra. I'm going to use the radial side of my index finger for the moving hand and the radial side of my stabilizing hand as well. I place stabilizing. For a more local emphasis of the transverse stretch to the paravertebral musculature in the cervical spine, the stabilizing hand can move to the caudal vertebra of the segment that you want to emphasize, and the moving hand is placed at the level of the cranial vertebra. I'm going to use the radial side of my index finger for the moving hand and the radial side of my stabilizing hand as well. I place stabilizing hand on the caudal vertebra. My cranial vertebra hand performs the pre-tension on the paravertebral muscle by performing a slight lumbrical squeeze, and the movement then occurs by pulling that local region of muscle in the direction of the subject or the patient's orbita. So I stabilize by giving a very gentle caudal pressure on the caudal vertebra, and I create a local rotation ipsilateral side bend by first taking a pre-tension and then pulling that level of musculature toward the orbita. I can either stay locally to emphasize that segment, or I can move cranially with my stabilizing hand, one level cranially with my moving hand, and get the same effect. And this can be performed from C7 in a cranial direction to C2. Transverse stretch to the suboccipital muscles can be performed in supine, and when this is done, the patient rests with the head and neck in a neutral position. The head is positioned in a side bend that is opposite to the side that I'm going to work on, and I'm going to create a very gentle rotation, side bend, emphasis to the soft tissue mobilization that's occurring. For this upper cervical transverse stretch to the suboccipital muscles, we're going to place our moving hand gently on the forehead, and the other hand is going to be placed between C2 and the occiput using the radial side in the region of the MCP2 of the index and MCP3 of the middle fingers. Pretension is taken up with a very gentle lumbrical squeeze of the hand. So, taking the suboccipital muscles on the right side, I'm going to create pretension, and the transverse stretch comes through a very gentle rotation toward the side that I want to affect. In this instance, I have pretension with a right, gentle right rotation of the cervical spine. And because I'm doing that right rotation and want to stay coupled, I'm going to place a very slight upper cervical left side nod, creating a contralateral movement pattern, left side bend with a right rotation, which is the coupling for the upper cervical spine. So creating pretension, pulling slightly ventrally and cranially, and creating the rotation through a gentle movement of the head by pushing the forehead in a rotation toward the side where my stabilizing hand lies. Soft tissue mobilization to the suboccipital muscles can also be performed in the form of a very local transverse friction at the insertions. The superior oblique muscle inserts on the superior nuchal line, and I can very simply find that by going from the external occipital protuberance to the superior nuchal line and gently working my way through the hair until I come onto the region of the scalp. Pressure can be applied along that superior nuchal line to find the most tender region, and then the hand stays there to perform the soft tissue mobilization. Index finger is reinforced by the middle finger, for instance. Pressure is exerted in a ventral, slightly cranial direction, and movement occurs from lateral to medial over the most tender spot. Insertion of the rectus, capitis, major, and minor at the inferior nuchal line can also be performed located by moving from the superior nuchal line to the inferior nuchal line region. Again, hair gently moved out of the way. The inferior nuchal line palpated for the most tender site. Index finger of the hand that's performing the technique placed flat against the inferior nuchal line, reinforced by the middle finger. Pressure is exerted in a ventral, slightly cranial direction, and pressure is again exerted with movement in a lateral to medial direction. Pressure, movement, pressure, movement, pressure, move, pressure, move, pressure, move. Only so much pressure is exerted that it's sub-threshold pain. The patient should feel it, but it should be either a good hurt or it should not be painful.
Now we're going to do dorsal ventral mobilization for C3 on C2, and we're going to move down and do a lower segment of C7 on C6. We always mobilize the caudal vertebral segment using the dorsal ventral mobilization. We typically use this mobilization to treat either a bilateral limitation that we picked up with our C6-7, our C2 to C7 side bending end feel test. If we have a bilateral limitation, we'll use this technique. In addition, this is also another nice technique for persons who are contraindicated for axial separation to treat a disc. So I'm going to find the lamina of C3 using my transverse processes. Find my mastoid, get on the transverse process of C1, fall into the indentation, come out on C3, I can now pull back the paraspinal muscles and soft tissue, push forward gently to load the tissue. So now I'm on the lamina of C3. Now in this position, I'm going to take the ulnar border of my hand to the lamina of C2, and I need to give a little skin towards my caudal hand. At that same time, I'm going to supinate my hand to keep my forearm off of her TMJ and face, and also to lock her head up against my chest. Now in this position, I'm going to simply stand up with my legs. You can see my fingers separating to give a little axial separation. So I stand up to get the separation. I want to maintain this separation throughout the technique. I want to extend until I feel C3 lamina start to push into my fingers. I stop. Drop my left hand so it's now horizontal to the floor, keeping my axial separation. You're going to perform a ventral translation holding 8 to 10 seconds. You can repeat anywhere from 5 to 10 repetitions. When you're done, release the ventral translation, return the C-spine to a neutral position, and release the axial separation. Now we're going to show the dorsal ventral mobilization, mobilizing C7 on C6. So to do this, we're going to come down and find our ventral landmark, which we found earlier in surface anatomy, using our first cricoid cartilage. Going straight dorsal, finding the spinous process of 6, moving down onto 7. I'll grab my towel. I can now pull skin back, pushing down onto the lamina of 7. Bring the ulnar border of my hand around to the lamina of C6, here. Supinate my forearm to lock the head. Now I can extend my knees, get the traction. You can see the separation of my fingers. Extend down into the segment right there. I can now drop my forearm so it's horizontal to the floor and mobilize with ventral translation, either rhythmic oscillations at the end range, or I can do 8 to 10 second holds at the end range. Repeat 5 to 8 repetitions. When I'm done, release my mobilization, return her to a neutral position, and release my axial separation. For a zygapophyseal joint limitation of motion and extension, we need to respect the anatomy of the zygapophyseal joint. And if you look at the zygapophyseal joint, you can see that C2 on C3, we are oriented on a line that is away from the orbit, going towards the base of the neck. So we want to respect that. And as I do the mobilization, you're going to see that my forearm will be along that plane, going away from the orbit. Where I'm going to block will be with my lumbrical grip, will be on the lamina of C3, here. I'm going to block perpendicular to the orientation of the zygapophyseal joint line orientation, here, about 45 degrees, caudal and ventral. Then I'm going to, the model will hold the hand. I'm going to hold here. My hand will come across, the ulnar border of my hand will come across into the lamina of C2. And I'm going to mobilize in the direction of my index finger, which is going to be dorsal, caudal, and slightly medial. So here's what it looks like. When we count down, using my transverse processes, fall into the indentation, back out onto 3. I can pull back the soft tissue and load the lamina here. Notice my forearm is now perpendicular to that orientation of the zygapophyseal joints. I'm going to now take the ulnar border of my hand along the lamina of C2, supinate my forearm to lock her head up against my chest and to avoid my forearm getting on her TMJ or her face, which can be uncomfortable. In this position, I'm now going to pre-position rotation to the end range. I'm going to add a coupled side bending, which is going to be to the left, until I feel that segment close down on my index finger of my left hand. At this point, I will bring my right forearm up into the plane of treatment, which will give me my extension for my three-dimensional motion. If you look, my forearms are essentially perpendicular to each other, and in this position I will now perform a rhythmic oscillation at the end range. My index finger of my right hand is in the direction of my mobilization direction. You can perform this for several minutes of oscillations. At the end, we can ask our patient to look up over her left shoulder. Very nice. And then relax. And then I can bring her back to a neutral position. C23 was shown as an example of the extension mobilization. However, this mobilization can be performed at any of the zygapophyseal joint levels in the cervical spine. Flexion and gliding of the zygapophyseal joints for the cervical spine can be performed at all levels. However, for this illustration, we will be performing the flexion glide at C5-6 segment. So as we did before, I'm going to stabilize the C5 lamina with my lumbrical grip. My forearm will be 45 degrees, so I'm perpendicular to the orientation of the zygapophyseal joints in the region. My ulnar border of my right hand is going to come around and cradle in the concavity of the C5 lamina. Now, when I perform my technique, I'll perform a local flexion only at the segment. I will then perform a coupled rotation and side bending towards me. And my direction of glide will be towards the orbit. So in this direction here, towards the orbit. So this is what it looks like. Okay, so we blocked the lamina of C6 using my lumbrical grip, 45 degrees, so I can lock the joints from C6 on down. I'm going to reach around with the ulnar border of my right hand. So I blocked the lamina of C6, 45 degree angle so I'm perpendicular to the zygapophyseal joint orientation. My ulnar border of my right hand is hooked on the lamina of C5. I'm now going to perform a local flexion into the segment, rotate towards me through the segment, side bend coupled to the right. I'm now going to elevate my forearm so I'm in the plane, going towards the orbita, and perform my gliding. You can perform this for several minutes. Then I'm going to ask the subject to look down at my right hip and relax. Bring them back to neutral and let off. A side bending mobilization for the uncovertebral joints in the cervical spine can be performed with emphasis on these uncovertebral joints here. You can see the rails coming up on either side. That's our uncovertebral joint. To emphasize this, we're going to use side bending. And what we're going to do is perform a translation of the C3 vertebral body on C4 to the right. As we side bend to the left, this vertebral body wants to slide to the right. And so we want to encourage this behavior. So to do this, I'm going to place my stabilizing hand, my thumb, on C3 lamina. I'm going to reach over the top with my ulnar border of my hand on the lamina of C2. And I'm going to perform a scooping, a sliding translation towards my body to perform this technique. We're going to perform it at C2-3 and also at C6-7. Block C3 with my thumb and my lumbrical grip. Reach around with the ulnar border of my hand into the lamina of C2. Supinate my forearm to lock the head. Now in this position, I am going to side bend the patient into the segment until I feel C3 start to rotate into my thumb. At that point I stop. Now, I want to allow the coupled rotation to occur. Don't fight it. They're going to go into a little bit of left rotation, and that's okay. Once she's in position, left side bend, slight left rotation, I am now going to perform a lateral or medial translation of C2 on C3 towards my chest. Taking her straight over by supinating my forearm and internally rotating. Performing a curved glide mobilization. We can perform this for several minutes. At the end, I can ask her to take her ear towards my hand and then relax. Take her back to the resting position. Then we can perform this at a lower level of C6 on C7. So I can use my ventral landmarks. Get on the lamina of C7 with my lumbrical grip, thumb along the right side of the spinous process. Now I've blocked the lamina of C7. My ulnar border of my right hand is going to come around, supinate into the lamina of C6. Now I'm going to side bend into the segment here, allowing the coupled rotation to occur. In this position now, I'm going to perform a rhythmic, curved translation, supinating my forearm, taking C6 vertebral body straight towards my stomach. We can perform this for several minutes. At the end, ask her to take her ear over into my hand and relax. Bring them back to the starting position.
Testing for provocation of the upper cervical joints can be done through a maneuver of protraction and retraction. The patient is positioned in a sitting posture, and again, in order to keep that nice erect but relaxed sitting posture, a towel can be placed in the low back region. Now what we're going to ask our patient to do is gently bring the head as far forward as you can, like you're putting your head through a hole in the fence. Keeping the chin relatively horizontal, I'll say forward, and I guide the head as far as I can go. Forward, forward, good. From here, I can further emphasize C1-2 by asking for a rotation. So I stand in front of my patient, I say from here, turn your head to the left as far as you can, maintaining that protracted posture. Come back and turn your head to the right as far as you can, maintaining that protracted posture. Good. come on back. I can emphasize C01 by asking for a side bend in this position. Side bend to the right. Good. Guiding the motion, maintaining the protracted posture. Come back and side bend to the left. Good. Come on back to an upright position. Good. From there, I can stress the capsules in a maximal upper cervical flexion position by means of retraction. So I will guide the chin now backwards, far as you can go. Good. And from here, again, asking for a right rotation, maintaining the protracted upright posture of the head. Go back to neutral. Turn to the left as far as you can, again maintaining that retracted position. Good. Come back, keeping your chin in. Now side bend to the right. Good. And side bend to the left. Good. And relax. So through upper cervical maximal extension, we test through protraction. Upper cervical maximal flexion, we test through retraction. Adding the rotation emphasizes the C12 joint. Adding side bend emphasizes the C01 joint. Those are our provocation tests for the upper cervical spine. From there, we're going to move on to mobility testing. We can get an idea of upper cervical mobility with a very quick test whereby we ask the subject to turn their head as far as they can to one direction, for instance to the right. And from here, I'm going to ask for cervical flexion, so chin down, maintaining the right rotated position, and then asking my patient to look up. Good. And come back. Excellent. And then we turn back to the middle and repeat the same on the left side. Sometimes patients need guidance. Turning to the left in order to prevent substitution motions, the therapist can maintain this position and then ask from here, gently look up, extending your spine, and gently look down, adding upper cervical flexion. This is a test specifically to test flexion from C0 to C4. We have another quick test for the upper cervical spine mobility, and that is a side shift or lateral shift test for C1 in relation to C0 and C2. In order to do that test, I'm going to locate the transverse process of C1, place my index finger on the most lateral aspect of it, and I tuck my index finger up underneath the mastoid. So the mastoid is against the radial aspect of my testing finger, and the pad of my index finger rests on the transverse process of C1. I gently snug my finger in. I estimate or register in my mind the amount of step that I feel between that lateral aspect of the transverse process and the mastoid. I then perform a pure side bend of the entire cervical spine, and in normal situations, the transverse process of C1 should make a very small lateral shift in the direction to which I'm side bending. And I register that with my index finger. So hook up, side bend. At the end, my step between transverse process and mastoid that my index finger is registering should be less. If it doesn't change, I probably have a hypomobility at the C0, C1 level. I repeat this test on the other side. C01 can also be tested in a traction direction. And C01 traction is tested by locating the transverse process of C1, placing the testing or feeling hand just superior and dorsal to that transverse process, and placing the moving hand at the back of the occiput and just behind the mastoid. I want to test C01 traction in a resting position of C01. So to do that, I'm going to put the alar ligament on slack on that side. The patient is sitting in a comfortable position. The therapist or examiner stands opposite the side that they're testing. So here I go. I'm going to take the left alar ligament off of stretch by side bending to the left. I add a very small amount of flexion by simply asking my patient to look down. Thank you. Oops, that was too much. So just think about looking down. Good. That's what I want, about 3 to 5 degrees. And then I'm going to stay coupled in that segment by bringing in a very slight rotation, again, only about 3 degrees. I recenter the joint, or my starting position is by putting a slight amount of compression through the head with my thumb. I push down, and my movement is a pull in a cranial direction. So my index finger of the caudal hand is listening or feeling for the gap that occurs, the very small gap that occurs when I simply lift mastoid and occiput and bring it back down again. So I'm going to lift and bring it down, lift and bring it down, lift and bring it down, and I do that several times, registering the amount of motion with my caudal index finger. I compare this amount of motion with my other side. I can do even more specific movement pattern testing of the upper cervical spine by stabilizing the caudal vertebra of the segment that I'm testing and actually moving the cranial aspect through its normal ranges of motion. For instance, at C01, I can stabilize the posterior arch of C0 by placing my caudal hand on the lateral regions of the posterior arch. By performing a pronation of my stabilizing hand, I emphasize that segment, that vertebra. The testing hand now is going to come against the occiput, placing the ulnar side of my hand against the mastoid and the posterior aspect of the occiput, bringing in some supination of my forearm in order to again be more local to that region. I give skin from caudal up, and I'm going to create a flexion motion at C01 by simply taking my moving hand, bringing the head into upper cervical flexion, and adding a very slight rotation towards the side that I'm testing with a very small amount, very slight amount, 3 degrees or so of side bend toward me. That creates a flexion, ipsilateral rotation to the side that I'm testing, and a contralateral side bend toward me, the upper cervical coupling pattern. To test extension in that joint, I will tilt the occiput backward, thereby creating a slight protraction in the upper cervical spine. Because I'm tilting the occiput backward, I'm going to also pull the occiput forward and rotate it towards me, so opposite the side that I'm testing. To stay coupled in the C01 segment, I'll allow a very slight side bend opposite to the rotation. I pull forward, and I test overpressure. So I'm going to note the excursion of the motion and the end feel. The entire test looks like this. Stabilizing 1, grasping occiput through mastoid, giving skin, flexion, rotation toward the side that I'm testing, side bend away, overpressure, and extension, pulling into protraction, rotate toward me, which is opposite the side I'm testing, and bringing in a contralateral side bend with overpressure. I'm then going to test the other side. So I can have my patient stand. I'm going to turn, down, good. And I will compare the amount of flexion on the left with the right, which I'm currently testing. Stabilizing, C1, grasping mastoid occiput, creating a flexion, rotation toward the side I'm testing with side bending away from the side I'm testing, overpressure and extension by pulling the head into protraction, rotating toward me, side bending away, and overpressure. That would be couple testing in flexion and extension for C01. I can do the same couple testing for C12. I'm staying on the right side, patient sitting comfortably. So to test the right side, I'm going to stand on the opposite side. Stabilize C2. Grasp now the lateral part of the posterior arch of C1 with the ulnar side of my hand. Supinate to get a little bit more emphasis onto that segment. Stabilize 2 against 3. And now what I'm going to do is create a flexion at C12. Again, bring in a rotation that's toward the side that I'm testing. To stay coupled, I'm going to add a slight side bend towards me. And I go to the end of the range and give overpressure. Extension is tested by creating a protraction in the upper cervical spine, and I pull in a rotation that's opposite the side that I'm testing. To stay coupled in the segment, I'm going to side bend, in this instance, to the right, which is opposite of my rotation, and I give overpressure. So, simply said, testing C12, I stand opposite the side I'm testing, I flex, rotate toward the side I'm testing, add left side bend, give overpressure. To test extension, I protract, pull a rotation toward me, opposite the side that I'm testing, and bring in a contralateral side bend to stay coupled in the segment. That's testing the right side. To test the left side, I again turn my patient around, support the low back, yes. Stabilize C2. I can push gently the lamina of C2 against C3. I'm going to come in with the ulnar side of my hand on C1, and to test the left side, in flexion, I flex, I left rotate, add a contralateral side bend to stay coupled in the segment, and give overpressure. For extension, I protract, rotate toward me, give a contralateral side bend, and I give overpressure. The C01 traction technique is performed with the patient in supine and the head starting in a neutral position. We're going to pre-position the C01 joint in a resting position. The therapist stands on the side that they wish to treat. The head is positioned so that the alar ligament on the left side is in a relaxed position, which means I'm going to bring in a very slight side bend, 3 to 5 degrees of flexion, and a contralateral rotation to stay coupled in this C01 upper cervical segment. The head position is held in that position with the cranial hand, and the caudal or mobilizing hand comes just caudal to the mastoid, hooking on with the radial aspect of MCP2. So getting in a position where the elbow is in a caudal position in relation to the hand, and pressure is then exerted in a cranial, medial, slightly dorsal direction. By doing this, a traction force is exerted on the left, for instance in this position, C01 joint. By simply taking the head and cradling it in my forearm, coming relatively low on my forearm, I bring in a slight left side bend, a slight flexion, and a rotation. Sometimes the table has to be positioned slightly down because I don't want more than about 5 degrees of flexion. There we go. Okay, so that leaves room for my forearm. I'm going to grasp the head, cradle it between my shoulder, forearm, and fingers so that I have the correct preposition for a resting position at the left C01 joint. I have slight upper cervical side bend, I have slight flexion, and I have slight rotation. My mobilizing hand comes in behind the mastoid, and my elbow is positioned in line of my force, and by simply pushing in line with my elbow, slightly side bending my upper torso, I am exerting a traction in the left C01 joint. This can be done statically as a static hold, or it can be done in an oscillation. Both techniques for pain relief. C01 dorsal gliding technique takes into consideration the dorsal surface of the C1 concavity in relation to the very convex surface of the occipital condyles. One would want to perform a dorsal glide to improve flexion in the C01 joint, and in so doing would preposition flexion in order to get the best stretch in a dorsal glide direction. To emphasize particularly the lateral side, or the lateral joint of this segment, the mobilization can be reinforced or even made more specific with a rotation component or rotation positioning to that preposition. So if I want to emphasize, for instance, the left side, I am going to stand on the right side. I preposition the occiput in a flexion position. I can bring the left condyle further dorsally in a left rotation, and to stay coupled in this segment, I'm going to add a very small right side bend. So it's flexion, left rotation, right side bend is a pre-positioning, and my glide is going to be then in a dorsal, lateral for the joint, and cranial position. My stabilizing hand lies on the posterior arch of C1. My cranial hand is the mobilizing force. So it looks like this. Patient is seated in a neutral position. Therapist stands opposite of the side to be mobilized. The stabilizing hand locates posterior arch of C1. Mobilizing hand hooks with MCP5 just ventral of the mastoid. The mobilizing hand elbow is placed in line with the direction of the mobilization, which in this case is going to be a dorsal, cranial, and for the joint, lateral direction. Stabilizing C1, hooking onto the ventral part of the mastoid, the rest of the mobilizing hand grasping the occiput and side of the head, leaving space for the patient's ear. Hold. Okay. I will now preposition in an upper cervical retraction, which is flexion. Bring in a little bit of left rotation, and to stay coupled in that segment, a right side bend. The rotation and side bend that one sees at the C0 joint is minimal. My mobilization force then is in the direction that you now see my index finger. I'm going to perform a gentle, either sustained or rhythmic glide for a dorsal translation at C01. This mobilization can be further strengthened or emphasized by taking out the activity in the upper cervical extensors. So I could say to my patient, gently look down towards your left hip. That reinforces my movement pattern. I get further into the range of motion, and I can continue to mobilize very gently from this position. Mobilization occurs at the end range of motion, so it's very important that one does not continually reset that preposition motion with every dorsal glide. The position is established, and the mobilization takes place moving beyond that end range. When I want to stop, I'm going to say, gently look down to the left, reinforce that, and relax. Ventral mobilization at this C01 segment is performed with a stabilizing force on the C1 vertebra. The mobilizing hand grasps the back of the head and the mastoid and pulls the condyle of the occiput forward, respecting the very deep convexity of the articular surface of C1. So if I'm going to clear the front edge of the C1 concavity, I need to pull that condyle of the occiput in a ventral, cranial, and medial direction. And that will afford a nice ventral translation at that joint. Ventral translation at the C01 joint is needed to restore extension. So I can best perform this maneuver by emphasizing one side. If I'm going to treat the left side, I stand opposite to that on the right side. C1 is stabilized, occiput grasped with the ulnar side of the mobilizing hand, little finger at the back of the occiput, MCP5 gently resting in the mastoid. Here we can increase the emphasis on the occiput by giving a slight supination movement to the mobilizing forearm. Here it is very important that I maintain an abducted position in my mobilizing shoulder, so to avoid exerting forces through the TMJ and the jaw of the patient. Prepositioning to improve extension and emphasize the left side entails a protraction or extension prepositioning for the upper cervical spine. I can bring the left side further forward by positioning a very slight rotation towards me, and I stay coupled by bringing in a contralateral side bend. So my positioning, one more time, is extension, left side bend with right rotation, and the force is a ventral, cranial, medial force. It can be performed in a rhythmic or static way. When I'm ready to stop my mobilization, I'll ask my patient to look up, very good, and gently to the right, and then I relax. C12 mobilization emphasizes the rotation and the flexion or extension component of the movement pattern at this joint. The joint surfaces, although the bony configuration does not give you a good view of that here, based on the cartilaginous covering, are biconvex joints. So the direction of our mobilization for this C12 joint is going to be essentially in a horizontal plane. Again, emphasizing rotation in either one direction or the other direction. The stabilizing hand is going to be placed on the lamina of C2, and one is able to stabilize C2 very well by pushing in a caudal direction of C2 on C3, basically C3 on C4, C4 on C5. And if one orients that stabilization in a line that's perpendicular to the local curvature to the orbita, then you get the best fixation. Mobilization then occurs by simply grasping C1 and occiput, performing the preposition, and then gliding dorsally by means of a rotation or ventrally by means of a rotation, keeping the mobilizing hand in the horizontal plane. Okay. Patient sits comfortably. The therapist stands opposite to the side being mobilized. So if I'm going to mobilize the left C12 joint, I locate C2, bring my thumb and radial side of my index finger against the lamina. I'm going to position my arm such that it is perpendicular to a line running from the local curvature to the patient's orbita. In order to ensure that my stabilizing hand stays put, I like to place my little finger at the junction of the upper trunk cervical region, and that is my guide to prevent any movement out of this stabilizing position. My mobilizing hand grasps occiput, and the ulnar aspect of my hand is snugged in by means of a supination of my forearm against the posterior arch of C1. Notice that my hands are very close to each other and that I'm not reaching around to grasp the occiput, but rather can stay quite lateral because that's the side that I'm emphasizing. Also with this grasp, note that my shoulder of the mobilizing side is staying quite abducted so that I leave the face and the TMJ free. When one pulls their arm in, there's a tendency to put too much force on the lower region of the patient's face. Stabilization, hand placement for my moving hand. Now for a dorsal glide, I'm going to pre-position the head in an upper cervical flexion, which is a retraction. I'm going to rotate to emphasize dorsal glide on the left. I'm going to rotate to the left, and to stay coupled in that segment, I'm going to side bend to the right. So my pre-positioning is now set. Retraction, left rotation, right side bend, and my mobilization takes place through a simple increase in that left rotation direction. Notice that my stabilizing hand remains steady. My mobilizing hand can perform the movement either through oscillations at the end of the range of motion or through a steady hold. I can increase the effects of this dorsal glide by taking out activity in the upper occipital muscles by asking my patient to gently look down and to the left. I increase the amount of rotation, flexion, and from there I can continue my mobilization. When I want to stop, I'll say to my patient, again, look down to the left, and I relax. Ventral glide is going to be performed also through a rotation. If I want to emphasize the left side, I'm going to stand opposite on the right side. C2 is stabilized by placing my radial side of my index finger and my thumb on the lamina of C2, pushing C2 in a caudal direction onto 3, 3 on 4, and so on. My stabilizing hand is aligned in a perpendicular to a line that connects the local curvature with the orbita. I place my little finger on the top of the shoulder or top of the trunk to ensure that my stabilizing hand does not move with my mobilizing hand. My mobilizing hand grasps the occiput, the ulnar side of my hand placed at the lateral aspect of the posterior arch of C1. For my ventral translation, I'm going to pre-position the head in a protraction or upper cervical extension. I can bring the left side more forward through a right rotation. So I'm going to rotate opposite to the side that I'm mobilizing. And to stay coupled in the segment, I'm going to bring in a slight left side bend. So I now have extension, right rotation, left side bend, And my mobilizing force is simply a furthering of the rotation to the right by a movement of my mobilizing arm in the horizontal plane. When I want to stop, I'll ask my patient, please look up and to the right, and I relax. The C0 to C2 segments offer us about 10 degrees of side bend, and that can be mobilized with a very simple side bending mobilization. During that side bend, for instance, side bending to the left, the vertebral body of C1 translates several millimeters ipsilateral to the side bending side, and we're going to promote that during our mobilization. So what we're going to do is stand on the side that's opposite the side to which we're going to translate, stabilize C2 against C3, and so on. Hold the occiput with the other hand, with the cranial hand, and the mobilizing hand actually is also your stabilizing hand. The radial side of the index finger stabilizes one side of the C2 vertebra. The mobilizing thumb now comes on the lateral aspect of the C1 transverse process, and the mobilization is performed by exerting a pressure against the transverse process of C1 while the cranial hand brings the occiput into a very slight, gentle upper cervical side nod. So it looks like this. Patient is sitting comfortably in the chair. Therapist stands opposite of the side to which the lateral translation is going to occur. C2, stabilized with the radial aspect of the caudal index finger. Thumb of the caudal hand is placed at the lateral aspect of the C1 transverse process. Cranial hand placed on the occiput and the lateral side of the patient's head. From a simple neutral position, the cranial hand performs an upper cervical side nod, and during this side nod, the thumb of the caudal hand exerts pressure to the side nod side, in this instance the left side, so encouraging and mobilizing the lateral shift that occurs in an ipsilateral direction during side nod of C0 to C2 segments. One more time. Position. As I side bend the upper cervical spine, I'm exerting pressure with my caudal thumb to encourage the lateral shift, also in this instance to the left. Notice that the side nod occurs only from C0 to C2.